Welcome back to the second part of this lecture, which is about the adverse drug reactions, or sometimes we call it in short ADR. WHO gives the definition of ADR as a response to a drug that is noxious and unintended, and it also occurs at doses normally used in man for the prophylaxis, diagnosis, or therapy of disease or for the modification of physiology function. These are the examples of ADR. For example, statin that we use for the controlling cholesterol in the patient, it also can cause muscle degeneration. And sometimes the symptoms often mistaken for a new disease, so the patients get unnecessary investigations and treatments. Therefore, it will affect the patient compliance with the treatment given. When we talk about pharmacovigilance, for example, this is about the signs and activities relating to the detection, assessment, understanding, and also the preventions of adverse effects of any drugs. ADR can be classified into two type of classification. The first one is Rollins-Thompson classification, and the other one is DOTS system. When we talk about Rowling-Thompson classification, it can be divided into augmented reactions, bizarre reactions, continuous drug use reaction, delayed reactions, the end of use of reactions, and the failure of therapy reactions. Augmented reactions resulted from the predictable pharmacological effects of the drugs, and it's one of the dose-dependent reactions. These are based on the pharmacological properties of the drugs, and it is very common for about 75% of ADR cases. And again, as I mentioned or highlight previously, it's about the predictable effects. The dose-dependent reactions and also preventable, it's also related to the augmented reactions, and this needs to reduce the dose or withdrawing the drug itself. And the effects usually mild, and it has high morbidity and low mortality rate. Bizarre reactions has no direct relationships to the dose of the drug of the pharmacological mechanism of drug action. So it is unpredictable from the known pharmacology. It can be developed on the basis of immunological reactions on a drug, for example, in the case of allergy, and genetic predisposition, such as J6PD deficiency and so on. A careful patient history will be identify this situation. Okay, for the type C, or sometimes we call it as a continuous drug use reaction, they are mostly associated with a cumulative long-term exposure, fairly uncommon and usually dose and time dependent. And then we go for the type D, or sometimes we call it as a delayed reaction. So type D is a manifestation with a significant delay, and these reactions are uncommon and also dose dependent. It also unpredictable, and usually it's time dependent. While for the type E reaction or end of use reaction, um, the drug withdrawal syndrome and also rebound phenomenon can occur with the type E reactions, and it is very uncommon and occurs soon after the withdrawal of the drug. The last one is the failure of therapy reactions. This is an unexpected failure of any therapy, and it is reaction is common and dose related. It also can cause by drug interaction. The examples of the failure of therapy reactions, such as in the resistance issue of antibacteria. For the first classification of ADR, as we already discussed just now, which is involved the Rollins-Thompson classification A, B, C, D, E, and sometimes it can go to F reaction. And for the A, B, C, D, E is more useful for the clinicians And the second classification of ADR dot system. This is more precise but complex, and this system is very useful for the research purpose. Okay, when we talk about the dot system, okay, from the words DO means dose related, and the toxic effects, the effects or the reactions that occur at doses higher than the usual therapeutic dose, while for the collateral effects, it's one of the ADR that occur at standard therapeutic dose. And the last one is hypersusceptibility reactions. The ADR can occur at subtherapeutic doses in a susceptible patient in certain patient. The second alphabet in the dot system, T, which represent the time relatedness. Okay, so when we talk about the time independent reactions, it can occur, the adverse effects can occur at any time during the treatment. And time dependent reactions, the reactions that occur at standard therapeutic dose, rapid reactions can occur when a drug is administered and it is too rapid. Early reactions occur early in the treatment and then abate with continuing treatment because of the tolerance of the dalam case of tolerance. And the last one, late or delayed reactions occur sometime after exposure, and sometimes it also can occur even if the drug is withdrawn before ADR occurs. The last alphabet in the dot system, S, is susceptibility. Right. So when we talk about raised susceptibility, can be present in some individual, but not the others. And increased susceptibility with these factors, such as age, gender, genetics, disease, pregnancy, drug interactions, impaired renal function, and also hepatic function. Let's look at to the first factors that can affect the susceptibility to ADR, which is age. For the elderly patient, they have the high risk of ADRs, maybe due to the multiple medical problem, and therefore they need polypharmacy for the treatment. Uh, Sometimes it's also increase in the patient with the history of ADRs and due to the reduced drug elimination process. For the pediatrics patient, due to they have the immature body system. For example, for the neonated less than 8 weeks, they have immature renal tubular function. Therefore, the hypoalbuminemia for that patient can affect the drug dosing, and also they also has the immature blood-brain barrier. The second factors that affect the susceptibility to ADR is gender. For example, women have lower body weight and also organ size, and they also have more body fat and different gastric motility and lower glomerular filtration rate. And these are the differences that can affect the pharmacokinetic and pharmacodynamic of drug. And sometimes women also more susceptibility to drug-induced torsade points, which is a form of tachycardia in which the electrical pulse in the heart undergoes a cyclical variation in strength, giving a characteristic electrocardiogram resembling a twisted fringe of spikes. For the patient with a hepatic impairment, such as liver disease, may have complex effects on drug clearance, the drug biotransformation, and also the pharmacokinetic of the drug. Cirrhotic patients may precipitate encephalopathy in the case of opioids and sedative effects. Right, for the renal impairment, it has a complex effects on the drug clearance, and the dose reduction is required for that kind of patient or renal impairment patient. And the creatinine clearance should be measured before initiating the new drug or new treatment for this type of patient. other factors is pharmacogenetic. All right. So for the example, for the patient who has CYP2C9 deficiency, uh, they may have a potential effect on warfarin metabolism, which can cause increased bleeding and also increased risk of toxicity. And another example is about the skin reactions such as Stevens-Johnson syndromes and the toxic epidermal necrolysis, which are more common in Southeast Asia population. And the FDA has recommended for this HLA B1502 screening before using certain drugs in this area or in specific Southeast Asia. These are the principles of treatment of drug toxicity event. The first one is to maintain vital physiological functions of the patient, and the second is to reduce or prevent absorption and the enhance the elimination to minimize the tissue concentration of the drug. And then the last one is to combat the toxicological effects of the poisons or the drugs at the affected sites. These are the strategies for the therapy of drug poisoning or drug toxicity. The first one is the supportive or symptomatic therapy. This is the include the serial measurement and the charting of the vital signs and important reflexes to judge the process of the intoxication, the response of therapy, and the need for additional treatment. The second strategy include the termination of exposure and the removal of the poison or drug from the body. This is to reduce further absorption. For example, oral administration of activated charcoal is created through controlled uh, pyrolysis of organic matter, and it is activated through steam or chemical treatment, which increases its internal pore structure and also adsorptive surface capacity. So the surface of activated charcoal contains carbon moieties that are capable of binding the poison ataupun the drugs. And the second strategy or the second way is by uh, whole bowl irrigation. By inducing the vomiting, use of emetic. Okay, so the alkaloid cephalin and sometimes imatine can be used within the syrup of ipecac such as ipecac that we use as emetic because of both local irritant effects on the enteric tract and also central effects on the chemoreceptor trigger the zone in the area post-trema of the medulla. And the second ways is using gastric lavage. So this is effective method for evacuation of the stomach, and the procedures of gastric lavage involve the passing and orogastric tubes into the stomach with the patient uh, in the left lateral decubitus position with head lower than feet. So after withdrawing stomach content, um, the saline lavage fluid will be administered and withdrawn. This process continues until the lavage fluid returns clear. And the last one is enhancing the elimination of drug or poisons, such as doing the manipulation or manipulating the urinary pH. Okay, so another ways is using the multiple dose activated charcoal, and the last one is administration of antidotes. For example, when we talk about antidote therapy, it involves the antagonism or um, drugs inactivation of an absorbed drugs. There are 5 rights of safe medication administration which can help practitioners avoid the medication errors. The first one is right drug, right patient, right dose, right route, and the right time. I think that's all. Thank you very much.